Previously, obsessive-compulsive disorder, or OCD, was classified as an anxiety disorder. However, OCD can be differentiated by its repetitive thoughts and behaviors. OCD exists on a spectrum from mild to severe and includes repetitive behaviors, self-soothing behaviors, and disorders of body appearance or function. Please be sure to look at the DSM criteria that's in your book and posted in the modules. There are two parts to OCD: obsessions and compulsions. Obsessions are recurrent, persistent, intrusive, and unwanted thoughts, images, or impulses that cause marked anxiety and interfere with interpersonal, social, and occupational function. Obsessions are thoughts. Compulsions are ritualistic or repetitive behaviors or mental acts that a person carries out continuously in an attempt to neutralize anxiety, but is usually not effective. Compulsions are behaviors. OCD is only diagnosed when the obsessions or compulsions interfere with the person's personal, social, or occupational functioning. The person knows their thoughts or behaviors aren't reasonable, but they feel like they aren't able to stop them. The person with OCD is attempting to control anxiety, but is usually unable to do so. They likely know their thoughts and behaviors aren't normal, so they try to hide them from others. OCD commonly begins in late adolescence, however it can show up in children, particularly males. Once in their 20s, OCD is distributed pretty equally between male and female. Symptoms will come and go over the course of a lifetime, however stress will exacerbate OCD symptoms. Late onset OCD is very rare. Some common obsessive thoughts are contamination, religious preoccupation, aggression, doubting, causing accidental harm to others, and sexual thoughts. Some common compulsions include checking to see if the door is locked or the oven is off, counting items like steps, cracks, tiles, etc., hand washing, chanting, touching either items or self, and arranging things in a certain order. There are several related disorders for OCD. Self-soothing behaviors include excoriation or dermatillomania, which is skin picking, onychophagia is chronic nail biting, and trichotillomania is chronic repetitive hair pulling. Reward-seeking behaviors include kleptomania, which is compulsive stealing for the thrill of stealing, not because the items are needed. Oniomania is compulsive buying. It's more common in females and is often seen in college students. Hoarding is the excessive acquisition of animals or useless items. It's more common in females and can be progressive and debilitating. Pyromania is repeated intentional fire setting because the person is fascinated by fire and feels relief when setting a fire or watching it burn. Body dysmorphic disorder is a preoccupation with an imagined or slight defect in the physical appearance that causes significant distress for the person and interferes with their ability to function in daily life. The person ruminates about the perceived flaw and blames it for their lack of success. They may undergo elective surgery to correct the flaw, but are still dissatisfied and may find another flaw to focus on. Those with body integrity disorder feel alienated from a part of their body and want it amputated. Most surgeons will not amputate a healthy body part, so these people may go to extremes of damaging the body part so that it requires amputation, or they amputate it themselves. The etiology of OCD is not well understood. Aaron Beck developed the cognitive model that describes a person's thinking as the belief that their thoughts are overly important, perfectionist, and an inflated personal responsibility. The cognitive model focuses on childhood and environmental experiences of growing up. A study of both fraternal and identical twins showed that genetic factors also influence OCD. OCD is fairly common across cultures in terms of diagnosis, but there are differences in how symptoms are expressed and beliefs about symptoms. Those who are very religious in both the Christian and Muslim faiths may have a heightened sense of personal guilt and believe that they should be responsible to control their unwanted thoughts. Some ethnic differences also occur. For instance, Asian Americans and African Americans report more contaminated related OCD symptoms than do European Americans. Gold standard treatment for OCD will include both medications and therapy. First-line medications include SSRIs like fluvoxamine, sertraline, and the SNRI venlafaxine. If the OCD is treatment-resistant, second-generation antipsychotics like risperidone, quetiapine, or olanzapine may also be used. Therapy is an important part of treatment for OCD. Cognitive behavioral therapy, or CBT, examines the relationship between the person's thoughts, feelings, and behaviors. Exposure therapy involves helping the person to intentionally confront the situations they normally avoid, while response prevention focuses on delaying or avoiding performing the rituals. Deep breathing and other relaxation techniques are also used to help manage the anxiety a person with OCD feels. Exposure therapy and response prevention may be used together. Patients and their families will need a lot of education about OCD. As a nurse, define OCD and teach them to recognize that person's symptoms. Help them to understand the importance of discussing the obsessions, compulsions, and anxiety. Emphasize the need for medication compliance as a part of treatment. Teach the patient behavioral techniques to help manage the anxiety and decrease the OCD symptoms. The family should be discouraged from giving the patient advice or fixing the problem. Help the family to be patient with their discomfort and to monitor their own anxiety level. Let the family know that it's okay to take a break from the situation when it's needed. The Yale-Brown Obsessive-Compulsive Scale is a tool nurses can use when assessing a patient with OCD. It's in your book in box 15.1. Remember that OCD is only diagnosed when the obsessions and compulsions interfere with the person's daily life, and they're only hospitalized when they can't carry out their daily routines anymore. We need to get a thorough history from the patient to determine when their symptoms started and any previous treatment that they've had. We also need to assess their general appearance and behavior, which should be familiar to you from the mental status exam. Patients with OCD will probably seem tense or anxious, or they appear unremarkable. Patients' affect may be sad or anxious, and they may report moods of overwhelming anxiety. Their thought process and content may focus on their obsessions, and the harder the patient tries to stop the obsessions, the more intense they become. They may report trouble concentrating and paying attention. The patient likely knows the obsessions aren't rational but feels that the thoughts can't be stopped. They can make sound judgments but can't act on them and engage in ritualistic behavior. They know they turned the oven off, but they still have to check it over and over. When looking at self-concept, the patient may feel powerless to control their symptoms or like they are, quote-unquote, going crazy. They may feel that if they were stronger, they'd be able to control their thoughts and behaviors. We need to look at the patient's roles and relationships as well. Is the patient able to fulfill their roles in life, whether it be at work or at home? And what's the effect on their support system? Are the friends and family wearing out? We also need to consider the patient's physiology and self-care. Anxiety can cause sleep problems, so we need to look into how the patient is sleeping. Is the patient losing weight from loss of appetite? How's their personal hygiene and their ability to complete their ADLs? As we put our assessment data together, it's time to formulate a nursing diagnosis. Some possibilities may include anxiety, ineffective coping, fatigue, low self-esteem, and so forth. Possible outcomes for patients with OCD may include the patient will complete daily routine activities in a reasonable amount of time. The patient will demonstrate the effective use of relaxation techniques. The patient will discuss their feelings with a nurse or social worker, and the patient will spend less time performing rituals. Some interventions may include using therapeutic communication, using relaxation and behavioral techniques, completing their daily routine in a reasonable amount of time, keeping a diary, and both patient and family education. This education can include teaching about OCD, the importance of talking about their anxiety, and teaching behavioral techniques. People may not understand why a person with OCD doesn't simply stop their behaviors. It may not make sense why a person washes their hands until they're cracked and bleeding, or refuses to eat anything not commercially packaged. It's important that you as the nurse understand OCD behaviors and that OCD is a chronic condition whose symptoms may come and go over the course of a lifetime. Treatment will likely include medications and long-term therapy to manage their OCD.